Hello and welcome to the webinar, Saturday at the Movies with the ISDS. And today we will review Barrett's before or after sleeve gastrectomy. Does it really matter? My name is Michel Gagner. I am from Chief of Surgery at the Westmount Square Surgical Center in Montreal, Canada. And there will be three talks that we will review. Bariatric surgery protects against Barrett's esophagus and esophageal adenocarcinoma, which is the national database study, which will be presented by Apoorva Chandar from Cleveland. Then Caroline Gronnier from Bordeaux, France, will present on the risk of esophageal and gastric cancer after bariatric surgery. And I will talk on the higher survival advantage for sleeve gastrectomy versus gastric bypass. Of course, those three topics will then be discussed by our discussants, Dr. Italo Braghetto from Santiago, Chile, and Dr. Joerg Zehetner from Bern, Switzerland. So please, without any delay, I would like to hear from Dr. Apoorva Chandar, who is at Cleveland, Ohio University Hospital, who will be presenting on bariatric surgery protects against Barrett's esophagus and esophageal adenocarcinoma from data from a national database.
Hello, my name is Apoorva Chandar from Case Western Reserve University in Cleveland, Ohio, and I'm here to talk about our recently published study entitled Bariatric Surgery Protects Against Barrett's Esophagus, a national database study. So what is Barrett's esophagus and why do we care? Barrett's esophagus is the only known premalignant precursor of a deadly malignancy called esophageal adenocarcinoma. Esophageal adenocarcinoma unfortunately has a poor prognosis. The 5-year survival is only about 20%. And almost all esophageal adenocarcinoma is thought to arise in a background of Barrett's esophagus. This is a graph that shows the exponential rise in esophageal adenocarcinoma since the 1970s. And almost 600% increase has happened up until the 2000s for unclear reasons. Obesity has really become a pandemic in recent years. The WHO estimates that 1 in 8 people in the world were obese in 2022. Since the 1990s, worldwide adult obesity has more than doubled and adolescent obesity has quadrupled. In the United States, per the 2017 to 2018 enhanced data, age-adjusted adult obesity was a staggering 42.4%. This is a graph that shows the parallel rise in obesity and esophageal adenocarcinoma. As can be seen from the graph, esophageal adenocarcinoma closely mirrors the exponential rise in obesity. So where does bariatric surgery fit into all of this? Obesity has been shown to be an important risk factor for both Barrett's esophagus and esophageal adenocarcinoma. And in particular, abdominal obesity is a major risk factor for both Barrett's esophagus and esophageal adenocarcinoma in a GERD-independent fashion. And we know that bariatric surgery, both sleeve gastrectomy and Roux-en-Y gastric bypass, are highly effective treatments for obesity. And this is how bariatric surgery fits into the whole picture. However, there's been some controversy in recent years regarding the risk of Barrett's esophagus after bariatric surgery. It's widely known that sleeve gastrectomy tends to worsen GERD. And as such, studies have looked into the prevalence of Barrett's esophagus after sleeve gastrectomy. A meta-analysis published in 2021 showed that the prevalence of Barrett's esophagus after sleeve gastrectomy can be as high as 11.6%. On the other hand, Roux-en-Y gastric bypass is supposed to be protective against reflux. But every once in a while, we come across patients who have had Barrett's esophagus or advanced malignancy developed several years after Roux-en-Y gastric bypass. In fact, recently we showed in a small case series a bunch of cases of Barrett's esophagus and esophageal adenocarcinoma developing several years after Roux-en-Y gastric bypass. So with this background in mind, we wanted to investigate the risk of de novo Barrett's esophagus after bariatric surgery, namely sleeve gastrectomy or Roux-en-Y gastric bypass. In order to do this, we used a large commercially available healthcare database called TriNetX. This comprises nearly 100 million patients across the United States. Our inclusion years were from 2009 to 2019. Inclusion criteria for cases were adults greater than or equal to 18 years who had undergone a bariatric surgery, either sleeve gastrectomy or Roux-en-Y gastric bypass. Exclusion criteria for cases included patients with revisions of bariatric surgery, those who had undergone gastric banding, or those who had intragastric balloons placed. For the controls, we used individuals who were undergoing a screening colonoscopy along with a concurrent EGD on the same day and who had never had an EGD before. Exclusion criteria for both groups were patients who had a history of peptic ulcer disease, anyone with a family history of GI malignancies, or a prior history of BEEAC. TriNetX uses a propensity matching algorithm, and we matched for common risk factors such as age, sex, race, smoking history, GERD, PPI use, diabetes, the use of weight loss medications, insulin, metformin, sulfonylureas, pioglitazone, and the presence of a hiatal hernia. For our outcomes and analysis, our primary outcome analysis was comparing the incidence of Barrett's esophagus in bariatric surgery cases against screening colonoscopy controls. We also did a subgroup analysis comparing the incidence of Barrett's esophagus in sleeve gastrectomy versus those who had undergone Roux-en-Y gastric bypass. Our outcome time frame was Barrett's esophagus at least 1 year after receipt of bariatric surgery. We also include a secondary outcome, namely weight loss in pounds and change in BMI. This is a busy slide, but it basically shows the baseline characteristics of the cases and controls. And if you pay attention to the right two columns, which is the after-matched columns, it shows that both the bariatric surgery and the screening colonoscopy controls were evenly matched in most parameters, with the exception of BMI and weight, which is expected to be higher in the bariatric surgery cases. The results of our primary analysis are shown here. In the primary analysis, which is the incidence of Barrett's esophagus 1 year after bariatric surgery, we were able to show that patients who underwent bariatric surgery had a significantly lower risk of the incidence of Barrett's when compared to screening colonoscopy controls. This significance persisted after matching, though it was slightly attenuated, as you can see from the odds ratio at the bottom right corner. We also did a subgroup analysis looking at the incidence of Barrett's esophagus 1 year after sleeve gastrectomy and compared that to Roux-en-Y gastric bypass. As can be seen from the two odds ratios both before and after matching, there was no significant differences between the sleeve gastrectomy and the Roux-en-Y gastric bypass groups in terms of the incidence of Barrett's esophagus. In our secondary analysis, we looked at weight loss and BMI 1 year into bariatric surgery. We were able to show that the bariatric surgery group lost a significant amount of weight after receipt of bariatric surgery, and they went down from 267 pounds to 211 pounds. Similarly, the BMI in the bariatric surgery cases went down from 41.8 to 34.3. On the other hand, there was hardly any change in the screening colonoscopy controls with regards to their weight or BMI. So, through this study, we have shown that there is a reduced risk of Barrett's esophagus with either a sleeve gastrectomy or Roux-en-Y gastric bypass. I would like to compare and contrast this with two big trials that were done in this field of bariatric surgery, which also included patients who may have developed Barrett's esophagus. The first one is the Swiss multi-center bypass or sleeve study, or the SMBOSS study. This is a randomized controlled trial where the authors were able to show that GERD worsened more often after sleeve gastrectomy when compared to Roux-en-Y gastric bypass. And in this study, 9 patients had to be converted from sleeve gastrectomy to Roux-en-Y gastric bypass during their 5 years of follow-up. And 1 patient actually developed de novo Barrett's esophagus. Another important study is the sleeve versus bypass study, or the Sleeve Pass study. The 10-year follow-up, this is also a randomized control study, and the 10-year follow-up of this found no significant difference in rates of de novo Barrett's esophagus between the sleeve gastrectomy and the Roux-en-Y gastric bypass group. In coming to the discussion about how bariatric surgery might play a role in reducing the risk of Barrett's esophagus, we need to look into how obesity might increase the risk of Barrett's esophagus. And there are 2 major mechanisms at play over here. One is a GERD-dependent mechanism, which is producing a mechanical effect of abdominal obesity on the lower gastroesophageal sphincter that might increase and worsen reflux. The second one is a GERD-independent mechanism, or a metabolic effect, which we will talk about very briefly. In obese patients, we have shown in a recent study in 2015 that there's an increased risk of Barrett's esophagus with elevated levels of obesity hormones. These hormones are leptin and insulin, as well as insulin resistance, measured using HOMA-IR. However, obesity also leads to low adiponectin levels, and this is also associated with an increased risk of Barrett's. Patients who undergo bariatric surgery have significant weight loss, which in turn results in reduction in inflammation caused by obesity. There's decreased leptin levels, there's increased adiponectin levels, as well as decreased circulating insulin and insulin resistance. All of this potentially contributes to the risk in Barrett's esophagus. I want to acknowledge some limitations of our study. First is duration of follow-up in our study is a bit unclear. So it's a bit unclear as to when patients actually develop their Barrett's esophagus. Second, it's also not very clear if any of the sleeve gastrectomy patients in our study underwent a revision to Roux-en-Y gastric bypass at a later date because of worsening GERD. Third, the Trinetics database relies on ICD-10 and CPT codes. And unfortunately, there's a lack of histopathology confirmation of Barrett's esophagus. It's also unclear as to why screening colonoscopy patients were undergoing an EGD on the same day. Presumably, this might be for GERD or dyspepsia, but this is unclear from our study. And finally, there's no information available about family history of Barrett's esophagus or esophageal adenocarcinoma in the Trinetics database. This is a slide that was borrowed from the American Society of Metabolic and Bariatric Surgery. And this shows the estimate of bariatric surgery numbers from 2011 to 2022. As you can see, from 2011 to 2022, there has been a very significant and steady increase in both Roux-en-Y gastric bypass and sleeve gastrectomy, but sleeve gastrectomy really seemed to have taken off with over 160,000 surgeries performed in 2022, whereas about 60,000 of these were Roux-en-Y gastric bypass. So in conclusion, bariatric surgery is a highly effective treatment for weight loss and can reduce the risk of development of Barrett's esophagus. A pre-surgical endoscopy or EGD is really essential to capture those with esophagitis, silent reflux, or those with Barrett's esophagus. And these patients should be preferentially offered Roux-en-Y gastric bypass as opposed to sleeve gastrectomy, given the evidence shown from prior studies. And further studies are needed to examine why certain persons develop Barrett's esophagus after Roux-en-Y gastric bypass. And with that, I end my presentation. Thank you very much.
So thank you very much, Dr. Chandar. We will have a discussion at the end. Second talk is the risk of esophageal and gastric cancer after bariatric surgery by Dr. Caroline Gronnier from Bordeaux, France. She is professor of surgery and head of the Esophageal Gastric and Bariatric Unit in the Department of Visceral Surgery at Bordeaux University Hospital in France. And after her talk, I will give the talk on higher survival advantage for sleeve gastrectomy versus gastric bypass. I am Chief of Surgery of the Westmount Square Surgical Center based in Montreal, Quebec, Canada.
Ladies and gentlemen, I'm very glad to participate to this very interesting webinar. I'm Professor Caroline Gronnier, head of the Upper GI Surgery Unit in the Visceral Surgery Department at Bordeaux University Hospital. I am involved in both bariatric surgery and esophageal oncological surgery. I would like to thank Professor Gagner more sincerely for inviting me to talk about a subject that is very close to my heart: the risk of esophageal cancer after bariatric surgery. I was very lucky to be able to work with Dr. Andrea Lazzati and Dr. Tigran Pogosyan from Paris University Hospital, based on French health insurance data on the risk of esophageal cancer after bariatric surgery. The data from the French health insurance system allow us to have access to all the data related to hospitalization on the whole French territory, with now a maximal insight of 10 years. We therefore wished to question this burning question of the link between bariatric surgery and the risk of esophageal cancer, the epidemic of which has been announced for many years by a potential increase in gastroesophageal reflux, particularly after sleeve gastrectomy. I have no conflict of interest on this subject. It is indeed established that there is a link between the development of cancer and obesity, such as endometrial cancer, colorectal cancer, and particularly for adenocarcinoma of the esophagus. In addition, several studies have shown a significant reduction in the risk of various cancer in association with bariatric surgery. The impact of bariatric surgery on esophageal cancers remains controversial, because on the one hand, it is expected that the risk of adenocarcinoma after bariatric surgery will decrease due to weight loss and hormonal effects, such as insulin deregulation, which may be involved in carcinogenic process in obese patients. But on the other hand, there is a fear of an explosion of the incidence of adenocarcinoma induced by gastroesophageal reflux after sleeve gastrectomy via the occurrence of endobrachyesophagus. Thus, we conducted with Dr. Lazzati and Pogosyan an article published in JAMA Surgery on the risk of esophageal cancer after bariatric surgery on national health insurance data. To do this, we performed a cohort study between 2010 and 2017, including 3.6 million patients with obesity. From this data, we conducted a case control study comparing approximately 300,000 patients operated on for bariatric surgery with 600,000 obese patients who were not operated on. Over the period studied, we found 339 esophageal cancers, with a significant increase in the incidence of these cancers in the bariatric surgery group and a decrease in intra-hospitalier mortality in the bariatric surgery group. There were young patients with an average age of 40 years and an average follow-up of 6 years, which requires further investigations. So our first question was, bariatric surgery does not increase the risk of esophageal cancer, but is there a difference between the different techniques of bariatric surgery? Therefore, we used the following method. We included all patients operated on for bariatric surgery from the PMSC database of hospitalization in France for adults over 18 years of age operated on for bariatric surgery between 2007 and 2020, with follow-up until 31 December 2020. We included patients operated on by gastric banding, sleeve gastrectomy, and gastric bypass. Patients operated on by a duodenal switch, being a rare procedure in France, were not included. Some patients could therefore have a sequence of several interventions, such as gastric banding, then sleeve, and then gastric bypass surgery, for example. The primary endpoint was the incidence of esophageal and gastroesophageal junction cancer with the following international classification of disease codes. We then performed a Kaplan-Meier survival analysis, followed by a multivariate analysis using a Cox model adjusted for gender, age, and comorbidities. Thus, we performed a sensitivity analysis, including only patients who had only one intervention to determine the specific effect of each intervention. We included a total of approximately 440,000 patients, 70,000 of whom were followed for more than 10 years, with the follow-up ranging from 1 to 12 years. A majority of patients underwent sleeve gastrectomy. Their average age was around 40 years, but patients operated on with a gastric band were significantly younger. The majority of the patients had a BMI above 40. There were significantly fewer patients with a BMI above 50 in the Bern group. Similarly, there were significantly fewer patients with a high morbidity score in the Bern group, while the other groups were well balanced. Concerning the incidence of esophageal and esophageal junction cancer, 104 cancers were diagnosed for an incidence of 3.8 per 100,000 persons per year. The majority of cancers were located in the esogastric junction and in the lower third of the esophagus, although 30% of the locations were not specified. The survival analysis gave a first impression of a difference between the three groups, with a discretely higher incidence in the sleeve group. But when we look at the multivariate analysis, we see that there is no impact of the type of intervention on the incidence of esogastric junction or esophageal cancer. We see instead, as expected, as an independent factor of esophageal cancer, the male sex and the increasing age. Sensitivity analysis, including only patients who had only one intervention, confirmed this data. The Kaplan-Meier analysis no longer shows a significant difference, and the multivariate analysis also shows no difference in terms of type of intervention with an effect of male gender and sex. This led us to ask a second question: is there a difference in the effect between sleeve gastrectomy and gastric bypass? Therefore, we conducted a study comparing gastric bypass and sleeve gastric binding and sleeve gastrectomy. In total, there were twice as many sleeves as gastric bypass, about 200,000 versus 100,000. The incidence of GE junction and gastroesophageal cancer was 0.021% in the bypass group and 0.025% in the sleeve group, without significant difference. After survival analysis model for the gastric cancer incidence, there was no difference between the two groups. This study has several limitations. First, there is no pathological analysis. It's young population, and the length of follow-up is about 12 years. And there is also survival revision surgery sequences. In conclusion, in this large cohort, with a large follow-up of more than 10 years, the incidence of GI junction cancer and gastric cancer is about 3.8% per 100,000 persons per year. And there was no difference between gastric banding, sleeve gastric bypass, on the incidence of esophageal cancer after adjustment. Thank you for your attention.
Hello, my name is Michel Gagner, and I would like to talk to you about sleeve gastrectomy having a better long-term outcome than gastric bypass as it relates to long-term mortality. Let me share my screen. Now, hopefully you can see this. So, higher survival advantage for sleeve gastrectomy versus gastric bypass. These are my disclosures. So, let's talk about long-term mortality, because one operation may be slightly better in terms of weight loss by a few percentage of excess weight loss, or can have slightly better type 2 diabetes resolution, but if it has some complications that causes reoperations, then the long-term mortality may not be different, or could be different. So I was alerted to this paper, the 5-year longitudinal cohort study of reintervention after sleeve gastrectomy and Roux-en-Y gastric bypass, which involved a colleague of mine, Dr. Anita Korkulas, when we were in the longitudinal study of bariatric surgery in the US. In the first figure of this paper, there is the reintervention after 5 years, which looks like Roux-en-Y gastric bypass has more reintervention than sleeve gastrectomy. This is in spite of sleeve gastrectomy perhaps having less weight loss result by a few percentage, and sleeve gastrectomy patients are having a revision. But in spite of that, there was a higher reintervention. And let's look at the numbers. The numbers in Kaiser Permanente, this is all a group of patients who have special insurance called Kaiser Permanente. And it's looking at about 12,500 patients in sleeve gastrectomy and over 18,000 patients in Roux-en-Y gastric bypass. And by year 5, you can see my arrow. This is the death rate in percentage. It's 1.9% for Roux-en-Y gastric bypass versus 1.3% for sleeve gastrectomy. Now, the numbers are small, but that is a 50% higher death rate in Roux-en-Y gastric bypass as opposed to sleeve gastrectomy. Let's look at more papers. This is coming from the Annals of Surgery, and you can see the rate of cardiovascular events and safety outcomes 7 years following gastric bypass versus sleeve gastrectomy. This is a study looking at over 5,240 propensity score match pairs. Now, if we look at MACE events, at 7 years, there was no statistical difference. If we look at acute myocardial infarction, it looks like there was also no difference, ischemic stroke, or hospitalization for heart failure. But we have to look at all-cause 30-day readmission. This reached close to statistical significance. There was in gastric bypass 4.46% all-cause 30-day readmission and 3.75% for sleeve gastrectomy. If we look at immediate post-op complication, it was higher statistically for Roux-en-Y gastric bypass. So Ryan Howard and first author and last author Justin Dimmick in JAMA Surgery published recently looking at comparative study of sleeve gastrectomy and gastric bypass up to 5 years after surgery. This is the cohort characteristics. Not much to say as the groups are quite comparable. But what was interesting was the cumulative incidence of mortality, complication, all-cause hospitalization, and all-cause emergency department use comparing to sleeve gastrectomy and gastric bypass. And you can see for mortality, it was higher for gastric bypass at 5 years. Complications were much higher with gastric bypass. Hospitalization was higher, and emergency department visits use was higher with gastric bypass. Now, also looking at reintervention, gastric bypass was much higher. Reoperation, gastric bypass was much higher. In revision, however, this is planned elective operations in sleeve gastrectomy was higher. But I would argue that there are options for sleeve gastrectomy revision when for gastric bypass, the case is difficult to make, and most patients will not have a revision of their Roux-en-Y gastric bypass, even if they have weight loss. Very few are undergoing revisions. Enteral access, again, was much higher in Roux-en-Y gastric bypass. Also, if we look at looking at this at the total health expenditure and total health care spending in 2018, there was not much difference between the two. Now, the Howard cohort was published again in Annals of Surgery in 2023. This time, there was more patients, about maybe 50% more patients. We're looking at 132,000 Medicaid patients, or more than 84,000 sleeve gastrectomy and 48,000 gastric bypass. The 5-year mortality was 1.3% for sleeve gastrectomy and 2.2% for gastric bypass. Again, a mortality that is 50% higher. This is confirming the Kaiser Permanente data, the first paper that I showed you. More complications, more reoperation, more ED visits, and more rehospitalization. This is a detail of the patient cohort, and at each of the curves that I showed you in the previous paper in JAMA Surgery, in Annals of Surgery, it is exactly the same curves and the same data, except that now with more patients, the mortality is even clearer, higher with gastric bypass. More complications, more hospital stay, more ED, and more revision was again higher with sleeve, and more reoperation with gastric bypass. Looking at a cohort from Scandinavian countries, long-term survival after sleeve gastrectomy versus gastric bypass, this is looking at 2 countries. It's looking at Sweden and Finland. This is the distribution of primary laparoscopic sleeve and primary laparoscopic gastric bypass. As you can see, in Sweden, the gastric bypass incidence has gone down after 2017. And in Finland, it has had a bimodal representation. Now, you have sleeve gastrectomy cohort and gastric bypass cohort. There were much more gastric bypass in Scandinavian country has been very popular for a long time. And sleeve gastrectomy, you can see, if we look at all-cause mortality, was 1.3% versus 2.8% in Roux-en-Y gastric bypass. Again, it's twice as much in terms of mortality. Here's another analysis in UK, perioperative mortality in bariatric surgery, meta-analysis of more than 4,300 patients. This is looking at the overall analysis of pooled perioperative mortality risk and mortality rate. Not much to say there, but on operation type, when they divided the subtypes of operation, you can see that the perioperative mortality was 0.05 for sleeve gastrectomy and 0.09 for Roux-en-Y gastric bypass. Now, this is perioperative mortality, not long-term mortality. Again, Ted Adams looked at published recently in obesity, long-term all-cause and cause-specific mortality for 4 bariatric procedures. This is a database from Utah of 27,000 patients. And looking at primary cause of death only versus the general population, you can see that all of those malignancy, diabetes, cardiovascular disease, ischemic disease is doing better. What's doing worse is external causes of death, suicide, and all accidents and adverse events are more in bariatric surgery. Especially here, suicide, I think it's of note. Now, if we break down the operations, Roux-en-Y gastric bypass, bending, sleeve, and duodenal switch, and you can see that sleeve, for all cause of death, was lower than with Roux-en-Y gastric bypass. Non-external causes of death, sleeve was lower than Roux-en-Y gastric bypass. Malignant neoplasia as well. Major cardiovascular event, same. Diabetes mellitus, slight difference between the two. And external cause of death, there was not enough for sleeve gastrectomy. So I have to conclude with this data that we have, and it may be confirmed by new ones that are yet to be published, that long-term survival are very reasonable for both operations, but long-term mortality is lower with sleeve gastrectomy than gastric bypass. And this may surprise a lot of people, but that is the case, even though gastric bypass may be slightly better in terms of weight loss long-term, type 2 diabetes effect, but there are problems with Roux-en-Y gastric bypass that we cannot deny. In spite of higher revision rates with sleeve gastrectomy, the long-term mortality is lower with sleeve gastrectomy. Thank you very much. So now that the talks are done, I thank very much the speakers for their excellent presentations. And it is time to have a discussant. We have 2 excellent experts in the field. Let me present those 2 discussants. We have first Dr. Italo Braghetto from Santiago, Chile. He is the Emeritus Professor of Surgery from the Faculty of Medicine at the University of Chile, and he's also an honorary member of several organizations, including ACS, American Surgical, Brazilian Society of Digestive Surgery, and a fellow of the International Society of Disease of Esophagus, and a member of IFSO. So he will give us his thoughts on this particular topic. We will also hear from Dr. Joerg Zehetner from Bern, Switzerland. Dr. Zehetner was professor at the University of Southern California, and he's a specialist in visceral surgery, upper GI and bariatric surgery. He practices within the Swiss One Chirurgie AG and the Center for Bariatric Surgery. He is a prolific operator and investigator for the LYNX device, one of the largest series in Europe, as well as reflux stop. So he will give us his thoughts on the topics that were presented. Thank you very much for attending this webinar. I hope you enjoyed it as much as I did. Thank you.
Thank you very much for the invitation to participate in this seminar dedicated to a very actual issue that was also analyzed in the last World Congress of OESO held in Strasbourg some days ago. There are 3 topics to discuss. I will participate as discussant. Regarding the first topic, I agree with Dr. Chandar in many aspects. The impact of obesity and its association with Barrett's esophageal carcinoma, of course, and the beneficial role of bariatric surgery as a protective factor for Barrett esophageal and carcinoma development. But, however, as himself mentioned, not only reduction of weight loss or hormonal mechanisms can help to decrease the development of the disease. There are also other anatomic and pathophysiologic well-described mechanisms post-sleep that must take in consideration because can induce Barrett and carcinoma appearance. Therefore, we must accept the balance of protective factor against factor favoring Barrett esophagus. In my opinion, it's important to avoid misperformance technique in order to avoid reflux. Regarding the epidemiological data, Dr. Chandar mentioned two papers proposing that bariatric surgery due to weight loss and other hormonal mechanisms are preventive procedure, but the exact way remains uncertain. He recognized that these procedures have bias and limitation, like follow-up short, no complete objective evaluation with endoscopy and histology, then the results are not consistent with most of the author and IFSO statement. More than 20 papers reported high-risk Barrett development after sleeve gastrectomy. Look the range, and IFSO in 2020 established Barrett development within 5 years after surgery. And then we will create a true at-risk population with a 6 times higher risk for Barrett development. But I agree with the final conclusion mentioned by Dr. Chandar because we need much better studied. Regarding the other topic, I agree also in many aspects with Dr. Gronnier, the relationship of obesity and gastroesophageal cancer, of course. She shows a figure demonstrating less incidence of cancer after bariatric surgery, but we must take in consideration other reports available on the literature suggesting, first, regarding adenocarcinoma after sleeve gastrectomy, mechanisms post-sleeve gastrectomy may contribute to increase the incidence of clinical gastroesophageal reflux disease, and then the progression to Barrett esophagus and potentially adenocarcinoma. And second, regarding adenocarcinoma after Roux-en-Y gastric bypass, this procedure by controlling acid and by reflux can have a preventing effect on the development and progression of Barrett's esophagus and carcinoma. But the exact mechanism for its persistence even remains unclear. For me, probably the association with misperformance technique can increase reflux due to a wrong technique. Avoid wrong technique like stricture, candy cane syndrome, hiatal hernia, large gastric pouch, etc. It is necessary also to investigate other noxious reflux that contents into the esophagus, as have been mentioned in the literature. Regarding the third topic, I agree with Dr. Gagner's concepts, but looking at the literature data, it is possible to observe different opinion lines. First, some report present similar long-term outcome for both procedures. Others suggest best long-term result after Roux-en-Y for comorbidities, weight loss, complication, reoperation, etc. And third, better result after sleeve gastrectomy, as Dr. Gagner mentioned. These lines are well described on the literature. Probably the better result presented by Dr. Gagner after a sleeve gastrectomy is the reason because this is the most performed bariatric procedure. But in my opinion, the Achilles heel for a sleeve gastrectomy are main two: GERD and regain weight with its consequence. Again, I press my thank for the invitation to participate in this very actual issue. Thank you.
Hello everyone. Thank you for being part of this excellent webinar. We have heard 3 excellent presentations. My name is Joerg Zehetner. I'm a surgeon in Bern, Switzerland. I'm originally from Austria, and these are my disclosures. I work in Bern in the Swiss One Chirurgy. That's a group practice of foregut, upper GI, and bariatric surgeons. And we work together with the Center for Bariatric Surgery, that's part of our group, as well as the gastroenterology group practice. And therefore, we have several teams doing interdisciplinary patient treatments. And my expertise goes together with the GI guys here when we treat reflux and Barrett's in patients or after bariatric surgery. Before I go into the individual papers, I want to mention some data that's out there, and that's if sleeve gastrectomy exposes the distal esophagus to severe reflux. And this was a systematic review and meta-analysis of 46 studies. And we see there is an increase in post-op GERD. There is a de novo reflux of 23%. There is a prevalence of esophagitis up to 28%, and Barrett's esophagus 8 to 17%. And there was even presentations that show a 3-year 10.5% low-grade dysplasia rate. So when we talk now about Barrett's esophagus and the development in esophageal adenocarcinoma, it was very interesting and new to me, and for sure to a lot of people listening and watching this webinar, that actually the rate of Barrett's esophagus was not different between sleeve and Roux-en-Y gastric bypass. Again, then we heard from Caroline Gronnier, Professor Gronnier from France, that the risk of esophageal and gastric cancer is not higher after bariatric surgery. And then Professor Gagner, thank you again for the invitation for this webinar, presented that there is actually a higher survival advantage for sleeve gastrectomy versus gastric bypass. So on the one hand, we have these findings that apparently sleeve gastrectomy exposes patients to an increased risk of progression of GERD. On the other hand, if you look at the data, at the real numbers, we don't see that increased risk. Just to remind you, what can you do after sleeve gastrectomy for reflux? I mean, first of all, the important thing is symptom control. Is the patient still having regurgitations? How is the BMI? How is the metabolic syndrome? And you should evaluate the motility of the esophagus, because if the motility is normal and the BMI is acceptably low, you consider the LINX treatment with the magnetic ring. The other option would be a conversion to a Roux-en-Y gastric bypass. The most important thing in reflux after sleeve is to rule out any narrowing at the incisura or a twisted sleeve, because then you might have to correct the sleeve and consider a conversion to a gastric bypass. If a hiatal hernia is present, I think it should be repaired if you do a LINX, but if you convert to a Roux-en-Y gastric bypass and the hernia is small, you might not need to repair it. So the pathomechanism of the sleeve, we know all this. It's the destruction of the angle of His. It lowers the gastric compliance. We have a high pressure system. In 40%, we heard if so, in Vienna, in 40% you have a hiatal herniation, gastric motility problems, esophageal dysmotility, and these are all the pathomechanisms that are pro-GERD. What do we have available after sleeve? We talked already about the bypass, and I want to mention the magnetic sphincter augmentation that we can only do if there's a normal motility. So why is there also reflux sometimes after bypass? And there is one interesting paper from Holmberg in Sweden. Let me go back in the slide to show you, which showed actually that there are also some mechanisms that are promoting reflux. So as well, the sling fibers are destroyed. Often we have a hiatal herniation, and we see patients developing esophageal dysmotility as well. But what's improving is the reversal of the weight, decrease of visceral fat. It is a low pressure system. We have low stomach pressure. The gastric emptying is better because the pouch volume is reduced, and as well the acid cells are reduced in volume. So what are our options after bypass? It's again medical therapy, but if you have regurgitations, you could think of resizing the pouch, repairing the hiatal hernia, and if the motility of the esophagus is normal and the BMI is low, you consider the LINX magnetic system if it's available in your area. Sometimes the hiatal hernia repair is feasible, and you might need to use a mesh to make sure it's repaired. So in general, remember reflux or severe reflux like development of Barrett's esophagus, think about making a more extensive therapy, increasing the PPI, but first of all treat the symptoms. As we've heard, the risk of cancer is actually low. What was interesting to me is that the LINX is actually now approved for post-sleeve since 2023. And we had a presentation at IFSO where we used the LINX after sleeve and bypass, and I don't want to talk too long, so I just summarized that it's a good option in refractory GERD for careful patient selection, but we had a significant revision rate, which was in sleeve about 40% and Roux-en-Y gastric bypass of 15%. So you can say the success rate after sleeve with the LINX was around 60% and after bypass around 75%. So we need larger cohorts and longer follow-up studies to see if that's a salvage procedure if you don't want to convert to a bypass. Thank you so much. So I think it was a very interesting webinar. It's very interesting to see that Barrett's esophagus seems not increased in sleeve than bypass. I'm a little bit concerned that this might not hold up after 5, 10, or 15 years. Because we are creating a kind of a reflux model there, but hopefully it stays like that, so we can offer the sleeve more liberally to patients that want to opt for the sleeve, as we want to treat obesity, and if we want to treat obesity, we have to find an easy procedure with less revisions and less mortality, and that's what Professor Gagner showed us in his presentation. Thank you so much, and thank you again for the invitation.